as osteosarcopenia. It's a very silent disease. We never come to know it's taking place slowly and slowly into our bones and muscles until and unless we face fractures. And it is complicated when it comes out speaking very loud. Why do we call it a silent epidemic? There was a survey which was done of 385 patients with fragility fractures, and they were asked, have you ever heard of osteoporosis? And a good 80% of them said, yes, we have heard. But when they were asked, do you think that your fracture could have been because you have osteoporosis? Only 27% of them said yes. That is, all of us are in denial. Though we know there's something called osteoporosis, we always think it is not us who tends to suffer from this. The thing that we need to understand that why is this term called sarco-osteopenia has been coined. It was done in 2009 by Binkley and Behring. And the reason why he coined this particular new terminology, because both osteopenia, osteoporosis, and sarcopenia are age-related disease. Both of them involve the bone and muscle unit. And it has been found that if a woman has sarcopenia, she is 12.9 times higher risk of having osteoporosis versus those who do not have sarcopenia. Further, the therapeutic interventions are common to both bone and muscle, and thus they're effective in treating osteosarcopenia. Further, if we compare osteoporosis or sarcopenia alone compared to patients who have osteosarcopenia, it has been found that the incidence of falls is approximately 3-fold time higher. Fractures are approximately 4-fold time higher in these patients. And further, if you find that the patient is at low risk of fracture, that is osteoporosis, she will automatically be escalated to high risk if there's a sarcopenia. And if they have been found to be categorized as high risk for osteoporosis or fracture, then they automatically move on to a category of very high risk. Hence, we all clinicians need to look for both of them when we tend to find one of them in our patients. If we look at the prevalence, it increases in both age and in women. As the age tends to advance, the incidence goes as high as about 30 to 40%, and unfortunately, it is women who tend to suffer from it much more. There was a study by Yu et al. In a cohort of older people who had hip fractures. The prevalence of osteosarcopenia was to the tune of nearly 30%, and the mortality rate was 1.8 times higher than those which had with or without its components. Now let us look at what are the risk factors. Age, of course, is the most common risk factor, and if age alone is responsible, it is referred to as primary osteosarcopenia. The second important factor is inactivity. As one tends to age, the periods of inactivity, mobility tends to become very restricted. And this inactivity is leading on to increased sarcopenia as well as osteoporosis. The third factor is the malnutrition, low protein intake, low calcium, low vitamin D. These all tend to cause a reduction in the bone as well as the muscle strength. Further, it has also been seen that in India, overnutrition, where you have very large amounts of fat, this particular fat tends to enter into the muscles and it tends again to decrease the power of the muscles. The fourth area we need to really look at is the disease. Whether they have got any endocrinological disorders like diabetes, mellitus, hypothyroidism, any of the inflammatory conditions like organ failure, malignancies, maybe they have rheumatoid arthritis or the CKD. Any of these comorbidities too tends to increase the risk. Thus, importance lies in taking a history about the falls, about the various risk factors, and the history should be taken not just from the patient, but also from all the relatives who accompany the patient. So now coming to the first component, that is called the sarcopenia. This is a progressive and generalized skeletal muscle disorder, which is associated with increased likelihood of adverse outcomes like falls, fractures, physical disability, and mortality. So how do we diagnose it? For this, we need to first identify our patients. To be able to identify, there's a very simple form which is called the SARC-F form. While these elderly people are waiting in your OPD to walk into your OPD, it would be good to circulate this form to them and ask them to fill it up. It is self-reported by the patient and thus reflects the perceptions of adverse outcomes that matter to the patients. It constitutes 5 components, which is related to the strength, the assistance in walking, whether they're able to rise from a chair, are they able to climb the stairs, and the falls. They're labeled from 0, 1, and 2. And if the score is 4 or greater, it is increasingly predictive of sarcopenia, or we would say that these particular patients are at a high risk and they need to be further evaluated. The next step of evaluation is to look at three components of the muscle strength, the muscle mass, and the muscle function. The strength is the most important, where we talk about the grip strength and the chair stand, which I will speak about. If the strength is low, we move to the next step to evaluate the muscle mass. And if the muscle mass has been found to be low, then we move to the third step, and that is to evaluate the muscle function. So how do we do the muscle strength? Now, this is by simple calibrated handheld dynamometers, which may be present in various of the gyms, or you can get it even online. They have to be well calibrated. The person sitting in straight with the elbows by the side and the forearm at right angles to the upper arm, with this particular dynamometer in the hand, and we need to apply the pressure. Now, if it has been found that the strength is less than 25 kgs for males and less than 16 kg for females, it is considered to be indicative of low muscle strength. Since this dynamometer is very easily available, it can be done in community healthcare and clinical settings as well as in the hospital practice. The second is a chair stand state. I think we all can do it while we are in the OPD to see whether our muscles are really strong or not. We need to put our arms across our chest, rise from the seat, and then sit down. And if we take more than 15 seconds for 5 rises, it is considered that our muscle strength is low. Now, this chair stand strength requires both strength and endurance, and it is considered to be a very convenient measure of the strength of all the muscles in our body. Whenever we find that the muscle strength has been less, we move to the next step, that is to assess the muscle mass or the muscle quantity, which is known as the skeletal muscle mass or the appendicular skeletal muscle mass. The gold standard is the MRI and CT, but we know about its high cost, lack of portability, trained personnel. The cutoff points are not well defined, and hence the DEXA is the one which is much more utilized. The advantage of DEXA is that very easily reproducible, but again, the instrument is not portable, and it has been, again, a little expensive, but definitely DEXA is considered to be one of the better methods of being able to assess the appendicular skeletal muscle mass. But the latest that has come into is the bioelectrical impedance analysis. It is affordable, it is portable, and may be preferable to DEXA. But again, we require far more study to validate its prediction for the specific population. Having gone to the second step, now we move on to the third, and that is the assessing the physical performance. When we assess the physical performance, we are basically seeing or predicting the severity of the disease. We do it by a gait speed. They're asked to walk 4 meters, and if the cutoff speed is less than 0.8 meters per second, it is indicative of severe sarcopenia. Then there's another way, we call it the short physical performance battery. They're about gait speed, balance test, as well as chair stand state. There's another one which is called the tug, where chair stand, walk to a length of 3 meters, turn around, walk back, and sit down. And the fourth one is 400-meter walk, 20 laps of 20 meters each. Now, when we look at these particular cutoffs, this has been given by the European Working Group of Sarcopenia in 2018. And these are the cutoffs which have been utilized. We need to have this chart with us to be able to remember what are the cutoffs and how we can categorize the patient. So putting it all very simply, if we are looking for probable sarcopenia, if they have low muscle strength, that is criteria 1, they're labeled as probable sarcopenia. If we need to confirm the diagnosis of sarcopenia, they should have low muscle quantity or mass, which we have already talked about will be confirmed by DEXA or by PIA. If we look at the severity of the disease, then we need to look at the third criteria, that is low physical performance. So if we see the whole algorithm of how we do, the first is we find the cases by doing the SARC-F form. If the SARC-F form finds that this particular patient is probably having sarcopenia, we assess it by doing the muscle strength. When we find the muscle strength to be low, we label them as probable sarcopenia. And in clinical practice, we can stop at this level because over here itself, we can bring about the interventions. But in cases of research settings or in cases where we need to go much more deeper, we move on to the third step to confirm the muscle quantity or quality. And if it is found low, then we go to see the severity of the disease by doing the physical performance test. We need to understand that this sarcopenia does not start in the old age, but it tends to start much, much earlier in one's life. It is considered a muscle disease, and a low muscle strength overtakes the role of mass as well as a principal determinant. And if the low muscle strength has been done, we do not need to move ahead to assess the mass or even to see the severity by doing the physical performance. We are fortunate to have a latest guideline which has come in 2021, which is called the SWOG-SARCO guideline. This is basically a South Asian working group guideline on sarcopenia. The question is, why did we need this particular South Asian guidelines when we had such a good guidelines from the European working group? The reason is that the muscle strength and mass is lower in the South Asians. This region is developing very fast, and we have a dual burden of over as well as undernutrition. We have something called a sarcopenic obesity, which is much more prevalent in us. And these particular countries are low income groups, and thus we need to bring about the diagnostic facilities as well as interventions at a low cost. The algorithm of the new guideline is 5S. You suspect sarcopenia. The chart they have called is the SARC-CAF, where they have included the calf circumference. We look for the causes of secondary sarcopenia. They look for the severity by doing the various physical performance tests, and then a shared decision is made for the optimal management. The strength of this guideline, it is the first expert opinion on South Asian population. It has an economic approach for screening and diagnosis, and it recognizes muscle strength and function over muscle mass. Now, this is important because for the muscle mass, we need DEXA, we need BIA. But for a muscle strength, it can be easily done by just stand-up chair and the function by means of a walking. So it recognizes the muscle strength and function as more important over the case of muscle mass. Coming to the diagnosis and screen for the next, and that's the osteoporosis. All the European guidelines and all the outside guidelines say that we should evaluate all postmenopausal women after 50 years for osteoporosis risk. But our own Indian Menopause Society says that opportunistic screening should be done in our women after 40 years of age. Even if they're symptomatic, any woman who comes to your clinic, for any reason, apart from that of a fragility fracture or osteoporosis, we should at that particular time take an opportunity by detailed history, physical examination, and using the fracture risk assessment to assess what is her risk of having osteoporosis. The main risk factors that we need to look on is advancing age, of course, but if they have a low body mass index, they have a prior history of fracture, there's a parental history of fracture, smoking, alcohol, use of corticosteroids greater than 3 months, and rheumatoid arthritis, all of them put them into a major risk factor. The tools which are very easily available, which can be downloaded in our mobiles, and we can immediately within seconds calculate what is the risk of them, is the OSTA score, which has been done for the Asians, and the WHO FRAX score. If you look at the WHO FRAX score, which has been concerned, it is very country specific. And now we are fortunate that this particular score is also available for our own Indian population. And in this particular score, we take the age, gender, weight, height, and we look at the risk factors. BMD, if done, tends to increase its accuracy, but it can also calculate your FRAX score even if you do not have a BMD. Now, what does a FRAX actually do? It tends to predict the 10-year absolute risk for a fracture in an individual, and it's a cost-effective analysis which tends to tell us which patients we need to pick up for interventions so that the development of fragility fractures can be reduced in these. The way it calculates is to the major osteoporotic as well as the hip fracture. If the major osteoporotic risk is more than 20% or the hip fracture risk is more than 3%, this particular patient is at much, much higher risk of developing fractures and requires intervention. The other simple score is the OSTA score, which has been actually developed by the WHO. It had 860 women from 8 countries, including from the Malaysia. It's a simple calculation of 0.8 into weight in kg minus age in years. The patients are stratified into low, intermediate, and high risks. This can easily be done by downloading the app on your mobiles. And what it tends to do it, if the patient comes in a high risk category, they have a 61% chance of having osteoporosis, while if they're in the low risk category, it's only 3%. Thus, the main function of this particular OSTA is to decide which of these particular patients require to be further evaluated by means of a DEXA scan. So now we come to the next, that what are the indications of doing a BMD or the DEXA scan? All postmenopausal more than 5 years should be advised to get a DEXA scan. Postmenopausal less than 5 years, who have any of the high-risk factors which I had already spoken of. Women in menopause transition with secondary causes, Any radiological evidence of osteopenia or their vertebral compression fracture, women with fragility fractures diagnosed on radiology before initiating any pharmacotherapy for osteoporosis. And as I've already said, it tends to find out even the appendicular mass, skeletal mass, and helps us to diagnose or to assess for the sarcopenia. Certain important things about BMD takes three areas. That's the total hip, the femoral neck, and or lumbar spine. 1/3 of the radius is only taken as a diagnostic site when the other sites are not preferred or not available. When the initial diagnosis of osteoporosis is made, we look at the T-score. And if the T-score is -2.5 or below, we label the person as having osteoporosis. Important to understand is that once the initial diagnosis of osteoporosis has been made, even the subsequent DEXAs, if they show the score to be better, the patient is still labeled as an osteoporotic. Repeat DEXA scans should be done every 1 to 2 years until the findings are stable, and preferably by the same instrument and preferably by the same technology to increase the quality or the assessment of the DEXA. So based on the BMD, the categorization is normal, -1 and above, osteopenia between -1 to -2.5, osteoporosis -2.5 or less, and severe osteoporosis of -2.5 or low with fragility fractures. In 2020, we have this particular diagnosis made, which is more practical. And if you have a look at it, any person who has -2.5 or below in the lumbar spine, we know is labeled as an osteoporosis. Anyone who has on an X-ray a low trauma spine or hip fracture, irrespective of the BMD, a score between -1 to -2.5 with the fragility fracture will be labeled to be an osteoporotic. A score of -1 to -2.5 with a very high FRAC score, they too fall into the diagnosis of osteoporosis. This is yet another risk categorization, and I think this is something which was published as a white paper in 2021. It has a very practical aspect to it. So who are the patients who are at low risk? All criteria should be present. They do not have fragility fracture, but they lie into the osteopenic because -1 to -2.5. We have done a FRAC score and we find that the FRAC score is low risk, less than 20, that is MOF, and hip fracture less than 3%. How are you going to manage them? Just optimize the calcium and vitamin D status, give them a bone-friendly lifestyle. We put them into high risk if any one of them is present, presence of fragility fracture, less than -2.5, or if your FRAC score shows that the MOF is more than 20% or hip fractures more than 3%. Apart from calcium, vitamin D, bone-friendly lifestyles, fall prevention, and we need to start appropriate anti-resorptive therapy. The very high-risk characters, any one of them, recent fractures, multiple fractures, severe fracture, fracture while on treatment, fracture while on bone-toxic drugs such as corticosteroids, if the T-score is less than -3, or if the FRAX shows MOF more than 30% and hip fracture more than 4.5%, these are the ones who would require appropriate anabolic treatment for 12 to 18 months, followed by the anti-resorptive therapy. So this categorization tells to help us practically how to treat the patients who do have mild, or to would say fall in the low risk, medium risk, or very high risk. Now coming to the last aspect, and that is the management of the osteosarcopenia. Lifestyle modifications, they form the basis. Alcohol intake, not more than 2 units per day. Smoking has to be stopped entirely. If they're addicted to caffeine, we say less than 3 cups per day. Tobacco, excessive salt is also an important factor, so less than 1 tablespoon per day. Maintain a very active lifestyle, including weight bearing, balance, and resistance exercises, and consider referral for physiotherapy. Nutritional, we have talked about calcium and vitamin D. Both of them are extremely important. And if you look at the calcium, recommended intake is more than 800. Preferably, all the guidelines are said between 1,000 to 1,300 milligrams per day. At one time, we need to limit the calcium intake to 500 milligrams at one time. And we need to explain to them at this particular doses, there's no risk of developing any stones or the cardiovascular events. Calcium carbonate is preferable because it's very effective and it is less costly, but calcium citrate has got less side effects. For vitamin D, I think I don't need to speak because all of us know about the vitamin D therapy that is there, but minimum requirement is 1,000 international units per day, and we should not be giving them more than 4,000 international units per day. Treatment is 60,000 units orally once a week for 8 weeks, followed by the maintenance therapy. Vitamin K to 7 is something else that we also need to assure that our particular supplements do have this. Protein is extremely important because it also helps calcium absorption, suppression of the parathormone, and it tends to develop into the bone and the muscle matrix. The amount of protein recommended is 1.2 to 1.5 grams per kg per day. 2.5 to 3 grams of this should be leucine per meal, and whey protein is specifically supposed to have a very high level of leucine. Every meal should have minimum of 25 to 30 grams. Another important point is that vitamin D levels should be in optimal range for an effective protein absorption. Diets, we know the diets which are very rich in proteins, that's the animal-based foods, or we have the plant-based foods, but they should be included in each meal. Exercise is the second point, when we talk of the resistance exercise and the balance exercise, at least 2 to 3 times per week, that is recommended. These are the different types of exercises: the weight bearing, the yoga, the strengthening exercise, the Tai Chi can be done, Pilates can be done. We need to look for the balance and resistance exercises. Everyone needs to be trained initially, and once they tend to train themselves, they can carry it on at least 30 minutes per day. Coming to the pharmacological interventions. Unfortunate for sarcopenia, we do not have any drug that can affect or treat the sarcopenia, although there are much more studies going, and we hope that in future it will be coming. For osteoporosis, we do have pharmacotherapy. The antiresorptive, the anabolic, as well as the hormonal therapy is available. In this talk, I'm not going to go in detail about, because that's another topic by itself. But the only drug, that is denosumab, is one which has been found to have promising effect in sarcopenia also, and thus it may be one of the drugs which can be used for the osteosarcopenia. 60 milligrams subcutaneous every 6 months. There should not be any hypocalcemia, that is calcium and the vitamin D levels should be well maintained, and they, once stopped, it should be changed over to the antiresorptive therapy. Thus, coming to the last slide, this is how the whole algorithm tends to go, that we need to do the SARC-F form. If they have been found to have sarcopenia, we need to look for the osteoporosis also by the DEXA, while DEXA also helps us to diagnose sarcopenia. And if they have sarcopenia as well as osteoporosis, we label them as osteosarcopenia, where we need to assess them. We start the non-pharmacological approach, we do the pharmacological approach, and then we follow these particular patients up. So our take-home points is osteoporosis and sarcopenia remain underdetected, undertreated. If we do have one of them, we should look for the other through the history, risk factors, physical assessments, and therapeutic strategies tend to affect both of them. And the most important is protein, calcium intake, exercises, but further research is required for the pharmacological treatments. The gospel for prevention of both osteosarcopenia is that we need to maximize the muscle and the peak bone mass in youth and young adults. We need to maintain it in the middle age, and we need to minimize the loss in the older age. Thank you very much.